A very good morning to all. And today we are once again in our vision and mission for saving mothers everywhere and preventing preventable mortality from postpartum hemorrhage. I welcome in the capacity of President North India Gynae Forum and as well a presidential candidate for FOGSI who has been evolved out of you. A gratitude for thank you for staying together for this long journey, incredible journey of 30 years in our vision and mission for women health as well as fellow OB-GYN across the country and done. This is NIGF. Please join NIGF, join Momentum of Unity, Excellence and Service. I bring greetings from land of Buddha who says we can never obtain peace in the outer world until we make peace with ourselves. And it is so very true of the core while we are dealing with the situations of the postpartum hemorrhage. The global perspective of postpartum hemorrhage is still a little bit gloomy. We are losing around 150,000 mothers annually across the world, and PPH is contributing to 30% and up to 60% of all maternal death, especially in developing and poor countries. And the conscious picking point is that the Africa and Asia is constituting major proportion of this hemorrhage-related maternal mortality. In India, the recent data says that the PPH is accounting for 35 to 56% of maternal death in India. And as a clinician, when we take the OB-GYN as a subject, we are bound to face it around 2 to 10% of all deliveries, out of which 1 by 1,000 can be massive and life-threatening. And we need coordinated, aggressive management so that we avoid the all complications of the PPH. And the story does not end over there. There is a long-term severe morbidity to the patient, and women who survive PPH are significantly more likely to have poor health as well as mortality in year following PPH. A lot of management issues like obstetrical hysterectomy, admission to ICU, massive blood transfusion are classified in category of near-miss, and the PPH-related mortality is a lifetime scar for obstetrician and our team. It is something what we know in our heart, and the postpartum hemorrhage tests the functioning of health system and the skill of health workers. Because it tests your leadership, it tests your guts, it tests your knowledge, skill, and it tests how much input you have given in your health system in day-to-day basis. Because PPH is many times unpredictable and it is sometimes present to us like a thunderbolt. All basic causes of the PPH are with the stone tissue trauma thrombin, and we are having a lot of new causes for the postpartum hemorrhage about which our classical textbooks are not mentioning how to manage these new morbidities which are causing a different presentation of the postpartum hemorrhage. These are the myomas, obesity, medical comorbidities, patients on the drugs, patient on the with the renal transplant, autoimmune disorder, and we have to have a different protocol for management of PPH in these cases. And in India, we still have all the issues which are age-old, like anemia, nutritional deficiency, 3 delays, safe delivery place, sound referral system, and we have to bridge many gaps in our healthcare system. So in today, I congratulate Dr. Shashi Kamra Maheshwari and the all team and the DGF, and my regards to Dr. Shardajan, who actually takes a baton for the assigning commitment and working for that commitment. And what we are going to see today, that is the prevention of life-threatening PPH, decision making, how to improvise the decision making, learning skills and the drills, because we don't want to have any mortality from the preventable postpartum hemorrhage. If we manage the suboptimally, especially in the golden hours, they can be, the implication can be numerous. It threatens well-being of mother, neonate, family, as well as the obstetrician, and a huge potential medico-legal media and the social issue. So alert readiness is the way, and this is the commitment should be from our side, that when when the patient reaches to us either for delivery or as a referred case, we must have no delay at our tertiary care facility, and we must have a blue code for alarm that everybody in hospital knows that this patient is having PPH and we have to have a coordinated care. A little bit about prevention of postpartum hemorrhage, which can be a question of $1 million as well as the day-to-day clinical practice. So, one or two points that identify in antenatal period what patient can be the high risk for the postpartum hemorrhage. Are they taking anticoagulant, but in the location of placenta, multifetal pregnancy, they are having preeclampsia. And after identification, you highlight that risk factor on the antenatal card, counsel family for PPH risk, treat all anemia nutritional deficiencies emphatically, and everywhere in the labor room, wherever patient goes, we must have this protocol. When this flashcard, this red flashcard is there that the patient is high risk for PPH, they take all necessary preventive and the curative precaution in managing the birth of the mother in that facility. Active management of third stage of the labor is like a vaccination against postpartum hemorrhage, because it shortens third stage, reduce PPH, severe PPH, need of blood transfusion, risk of anemia, and every woman who delivers in the institution have the right to have a active management of third stage of the labor. And the most strong arm is the administration of oxytocin agent within 1 minute of birth of baby after excluding presence of second baby. Oxytocin 10 unit IM or IV is a standard thing, and now we have got the carbitocin, which has added as a beautiful armamentarium for the active management of third stage of the labor. Misoprostol is a reasonable cheap agent which does not require the like a refrigeration and the cold storage, yet it is a second choice for the active management of third stage of the labor. And when we do it, especially in community setting, the route should be oral or the sublingual. So all professional bodies strongly says that every woman who delivers must have the active management of third stage of labor, and carbitocin has been a paradigm shift in the preventive aspect because it has a very, very strong affinity to oxytocin receptor. It has a much longer lasting effect than oxytocin, and it is a vendor drug because it adds to the thickening of the blood and further prevent the postpartum hemorrhage. After champion trial in which India contributed a lot with the 30 facility across all 4 zones, and one or two thing about the use of carbitocin, it is to be used only as a single agent. Dose, it is not to be repeated because carbitocin have a strong affinity to oxytocin receptor. Only after delivery of the infant, and use of carbitocin should occur in the other measure when to prevent postpartum hemorrhage. In cesarean as well as vaginal delivery, the route is 100 microgram 1 ml, IV or IM. If it are given IV, it is to be given over 1 minute. It eliminates the requirement for infusion, oxytocin infusion after initial days. So especially in a woman when we don't want prolonged oxytocin infusion, like anemia, valvular heart disease, preeclampsia, hypertensive disorder of pregnancy, carbitocin is the drug of choice as a active management of third stage of labor. Important thing is that these drugs should be available, whatever we know, but these drugs should be available at the bedside of laboring women with the adequate cold storage, and every skilled birth attendant must be knowing that these active management of third stage of labor, especially the administration of oxytocin agent within 1 minute of the birth of the baby, is the most important practical aspect. Controlled contraction, now WHO have given the word that always to be done when a person is experienced for it. Late cording clamping as a component for active management of third stage of labor has additional benefit to baby, and uterine massage is not recommended routinely. Yet PPH is unpredictable in many situations, and you have to have a more sweating in the piece so that less you bleed in the bath when you encounter the case of PPH. And we have to have the carry out drills regularly. We are having pan India more than 100 physical and virtual workshop, and many persons from the Delhi and the North are actually spreading their knowledge about the PPH. Why do mothers die from PPH? Because there is a delay in correction of hypovolemia and delay in control of bleeding. And here we have to look for the aggressive resuscitation and the medical management. Golden hour is the first hour after beginning of PPH when resuscitation measures give you the best chance of survival of mother. So one message which I want to give, don't shift the woman to the postnatal ward before the lapse of 1 to 2 hours, and every nurse and the resident must be knowing what they have to look into golden hour, that is breathing PB, tone and height of uterus, vitals, general level of alertness, GIT and respiratory system pattern, and the oxygen saturation. To August gathering, it is primary PPH, secondary PPH, but 500 ml or any blood loss which makes the woman and hemodynamically unstable. But when you are called to a case of PPH, first make a quick 360-degree review of whole situation, because the cause analysis is very, very important. And while we are having all planning for the resuscitation and the initial management. So cause analysis, tone, tissue, trauma, thrombin, we all know as a obstetrician and gynecologist, but important thing is that you have to correlate it in this particular case, what is the cause of the bleeding. It is atony if you have done a prolonged induction, high parity, chorionitis, or the over distended uterus, it is atonic, or the uterine inversion when you don't see the uterus or it has been difficult delivery. So the cause analysis, considering all history, so you have to take a 360-degree review. What were the antenatal record, what were the placental location, what were the history, and what were the drug intake. So cause analysis is very, very important, and always think of not one cause, because in one patient you can have multiple cause, like we have the prom infection, which cause atony, we have used atolytic previously, and then the difficult delivery of placenta. So the multiple cause can be there. Why we still find the difficulty in diagnosis for PPH till now, we lose the time of golden hour, because woman remains normotensive, because the nature has been kind enough to make the woman hypervolemic in the pregnancy. So many times we actually lose the time of 1 hour, and suddenly we find a patient is in the shock. Visible estimation of blood loss, thanks to across the country our PPH like workshops and the thing what we have. So we have improved a lot with the estimation of the right estimation of the blood loss visibly, and the PPH can be concealed in case of hematoma, rupture uterus, flabby uterus, and whenever you find there is a unstable vitals in presence of not so revealed bleeding, amount of bleeding, we have to work on it. However, you give clear instruction to labor room staff. That is very, very important. So they are not confused when to call, how to call, wait or not to call. If the patient have 5 soap normal size pad, 1 soap big sanitary napkin, she is having continuous trickle of blood, or you are using any Chhattisgarh or Devdas bag, or the patient's altered condition, she is confused, she is vomiting, she is having a little air hunger, that is the time you have to look at the patient is not having internal or external bleeding. Blue code is very, very important. This is the thing what we have to change in our system, because you cannot manage PPH alone. We need several pair of hands and brains. We need a full team. We have to call anesthetist, senior nurse, obstetrician, colleague, ward, smartest ward boys and guys, theater staff, and the blood bank person to be notified. So blue code should be there, that there is a patient and all person from the hospital come to your rescue to give you the all necessary help. So what is, you have to have a quick thing, what is the general condition, what is vital parameter, she is unconscious, what is the amount of hemorrhage. So it is a minor, major, or the moderate. Pulse, systolic pressure, tissue perfusion indicator, what is amount of urinary output, and the capillary refill. These are simple clinical thing out of which you can easily make out that what level of the hemorrhage you are dealing with, and your aggressive resuscitation and the accordingly further management should be guided by this thing, that the pulse is more than 100 or not, or what is the blood pressure, and you can make a good refill. Shock index is very, very simple thing. If the patient, you are having the cardiac monitor, simple one also, then maternal heart rate divided by systolic blood pressure, and if it is less than 1, you have a breathing space, but if it is more than 1, then you have to be very, very aggressive. And for this, in our all labor room, whether we are having the 7 deliveries in a month, we must have the cardiac monitors must be there alongside our laboring women. A rule of 30, again, that is the same thing, clinical pulse systolic, pulse rises by 30 minutes, systolic blood pressure falls, respiratory rate rise, and the urinary output falls. So rise, fall, and that gives you fair idea. Once you recognize and the cause analysis is under your mind, you want certain things. You want all drug, oxygen cylinder, air weight, PPH rate, which we are going to discuss, chart for PPH management, and all persons we want to have. Start with the basic IMO. We will just go the fluid resuscitation, how to do catheterization, having the 2 IV line, that is very, very important. And always, even if it is a minor hemorrhage, you have to have a close watch for the monitoring and the readiness for resuscitation, because sometimes you think it is a minor, but in the next 1 hour, it becomes a moderate to the severe hemorrhage. It is important when you have the apparently smaller blood loss, but the sign of shock like oliguria, delayed peripheral capillary filling, always rule out with a quick hemoglobin and a quick ultrasound that the patient is not bleeding internally, and we must have the full protocol of the measure. Never scold anyone if you have been called for the PPH or you find that the patient is okay, because next time they will be like frightened about it, and it is something in non-technical aspect of managing PPH. Call for help, airway, breathing, circulation, give oxygen at rate of 10 to 15 liters per minute, regardless of oxygen concentration, and always the 2 IV axis, that is a green and the gray cannula. There should not be any pink cannula in the laboring woman. Keep patient flat, keep patient warm, and until blood is available, that is a life-saving thing, that infuse up to 3.5 liter of warm crystalloid fluid rapidly. If you have not given oxytocin, give at this time. Always catheterize to see what is amount of urine. Secondly, it is not blood stained. And thirdly, what is the amount of urine, so that you can assess what is the level of shock and assess need for blood transfusion by bedside Hemu test. So the indices of shock, a very quick watch on the indices of shock and the hemoglobin level is very, very important. If catastrophic hemorrhage, we must be having that skill to do the aortic compression, especially in the adherent placenta accreta spectrum. We find certainly that amount of severe blood loss. So resuscitate, investigate, monitor, communicate, and record keeping. The moment you find that this is the patient with PPH, a good communication is a must for medical legal purpose, for getting cooperation from the patient. And when you are putting these green and the gray cannula, take at this time, you must have these all 6 vial, 3 plain vial, 2 EDTA vial, and 2 citrated vial. And these vials should be in your this PPH toolkit with the blood requisite form of the blood bank, because you cannot have the waste of the time by finding out that where these vials are there, as well as the blood transfusion requisite form. So you want to have a baseline CBC, bilirubin, electrolyte, creatinine, sugar, blood group cross matching, prothrombin time, and the fibrinogen and the D-dimer time. So the PPH care bundles, which is a set of few groups of the clinical practice which can be beneficial, and this is the E-motive bundle which concentrate on all these issues, what is a uterotonic drug, crystalloid, tranexamic acid, butyrinosal. So after airway and the initial resuscitation, it is a crystalloid, and the crystalloid are very, very important. We should choose the ringer lactate or the normal saline, because crystalloid rapidly equilibrate into extravascular space, and only 20% of crystalloid remain intravascular in critically ill patient after 1 hour. If you are estimating that she has lost 1 liter, give around 3 liter of the crystalloid. Never start with the colloid, because it remains intravascular for a long time, more chance of pulmonary edema, and it interact with the coagulation test. So crystalloid is the choice of the fluid. Ringer lactate, normal saline 3 times up to the estimated amount of the blood loss. When the patient has received around 2000 ml or 2 liter of fluid and the blood is not available, then you can add in between colloid up to 1500 ml. Ask right question if placenta is delivered. If it is not, it is complete. So never throw the placenta strict instruction to the staff, never throw the placenta in biomedical waste disposal unless the 1 or 2 hours have passed. Delivery, bleeding started immediately after delivery of baby. Maybe the genital tract trauma, placenta is delivered, then not delivered. If not delivered, you have to mobilize MRP. And if there is a suspicion of past disorder, no attempt should be made to remove the placental part. Always catheterization, I have emphasized fundal massage, that is a art of the circular movement of left hand on fundus of the uterus. Evacuation of blood clot to be removed because it enhances the uterine contractility, and identify fundus of uterus carefully in obese women. Medical management, we are fortunate in this era that we have a variety of the drugs which act on the different aspect of the PPH, different case situation. Oxytocin, carbetocin, methyl ergometrin, bisoprostol, and the PGF2 alpha. We have to see very, very important 2 things: ruling out contraindication of each drug. Secondly, the good cold storage, what is desired for that drug. And thirdly, the optimize the dose of drug. It is not so you give only 1 or 2 doses of the prostaglandin F2 alpha or methyl ergometrin, only 1 drug. So important thing is that these drugs must be available to us. Everybody should be knowing what is the contraindication of methyl ergometrin, that is hypertension, anemia, heart disease, PGF2 alpha, bronchial asthma. So we have to have the very good knowledge as well as availability, and always optimize the drug, and they must be available in our fridge. And beside cardiac monitor, refrigerator is the thing which must be close to our labor room, definitely. So if the one drug fails, you use another drug. If the another drug fails, you use the second dose. So this is important because every uterotonic drug is affecting on different receptor, and we have to optimize the drug. So the right use of drug, right storage of the drug. However, if you have used around 3 doses, then the bleeding is not controlled like PGF2 alpha. You have given 3 doses of methyl ergometrin or the 1000 microgram of misoprostol. This is time that we should be ready with our second label measure. Tranexamic acid has come in a big way after the women trial, and it has been shown to be a very effective drug if we utilize tranexamic acid within 1 hour of the diagnosis and repeat it within 3 hours. So all recommendation after women trial, and you can give prophylactically tranexamic acid in the postpartum hemorrhage patient who have the high risk. Be aware that the tranexamic acid ampule is very much resemblant to bupivacaine, and sometimes there has been the inadvertent injection of the tranexamic acid for the neuroaxial block, and that caused criticality and mortality. This is a paper from anesthetist, very recent paper from Western world, and we have the cases in NMC also. When to organize for think of blood transfusion if moderate to severe PPH. HemoQ says that hemoglobin is less than 7 gram, patient is having ongoing bleeding, and any predisposing condition which cause the DIC or the coagulopathy, which are placental abruptio, severe preeclampsia, HELLP syndrome, IOFD, DIC, and amniotic fluid embolism. We should have now a lot of test coagulation profile, and very quickly we get, still in many settings, we need the bedside clotting set and the clotting retraction test. And a wonderful paper by Dr. Nalini Mishra says that bedside clotting test have a very good correlation with the fibrinogen level. Massive transfusion protocol, 2 things just I want to say, that massive transfusion protocol start after 3 to 4 unit of PRBC and patient is having bleeding. After that, it is a start, then it is a 1:1:1, that is the RBC, FFP, and the platelet. Though the studies have been done usually on non-pregnant women, but the massive transfusion protocol, especially in placenta accreta syndrome, especially in the patient with DIC, we have to be ready. And what we want to achieve after the blood transfusion, that is a certain parameter: hemoglobin more than 8, platelet count more than 75,000, prothrombin less than 1.5, and fibrinogen more than 1. So we must have, when is the need of blood transfusion, what is the type of blood transfusion. Always record vital parameter, event, type, amount of fluid, and communication is very, very important. Cause analysis, MRP, placenta retain, mobilize for MRP inversion. You have to repair all the laceration. And MRP again is the thing, manual removal of the placenta. It has got its own skill, but the golden word of Ian Donald, that the real difficult part about MRP is the decision to undertake it. So take swift decision when to shift to OT, when to open up. You want to have what conservative measure versus obstacle hysterectomy. You want to do selective revascularization, develop skill and the practice skill. So finally, we have to save life and drastic situation need aggressive measure. Set protocol for everyone in the team. Desensitization, medical, conservative surgery, radical measure. Take swift wise decision. Get ready with your team. Prepare team of friends, very, very important. And if hysterectomy needed in rapidly deteriorating situation, do it. Have a sharp eye on potential medical legal issue. Keep good communication, even in worst of the circumstances. So it is postpartum hemorrhage. If you can fill the unforgiving minute with 60 seconds worth of distance, run, run, run. We wish to hope. I really regret that I am not personally present there because of some emergency commitment. And I wish that with the leadership of Dr. Sharda and Shashi Kabra and whole of the wonderful faculties which we have across the country, you will have a very, very enjoyable session. So leadership is all about commitment and conviction. I seek, first, I have a gratitude to electing me for the president of North India Gynae Forum. In 1 year, we have crossed many milestones, and I seek your full-hearted support, blessings in my forthcoming election. And I am ready with the vision, and we have much to do together. Please, thank you for the active listening, and thank you for the opportunity.